Assalamualaikum.
Waalaikumsalam, Doktor.
Good morning.
Morning, Doktor.
How are you? Are
Alhamdulillah.
you Hisham?
Yes.
You have about 1,000 days to be Akmal in medicine, inshallah. How many participants now? 29. How much is your batch?
We have 36.
How many candidates supposed to attend?
36.
So still lagging for about 6 candidates.
Yes.
You must be ready on time, inshallah. Okay. Let us give them a few minutes if they come. Until 10 minutes, I will notice for that. Okay. Let us start by al-Kitab. بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين اهدنا الصراط المستقيم Can you hear me?
Yes, doctor.
Yes, sir.
The net of the hospital is interrupted. I am also connected from my mobile in case. The most important about dermatology, it is a very good entrance to the body, and it gives you clue, especially if you are a good observer. Good observation is the first and the important job of us in medicine. That's why I advise all my students, don't jump to the patient, even after, we'll speak for that inshallah in the future, after introducing yourself and get permission from the family and washing your hand and or doing hand rub and exposing the patient and put him in the correct position. You must come back by one step, not enter to the patient, either heart, abdomen, chest, nervous system. Come back and try to put observation. Observation from bit wide, like in the foot of the patient, the top of the bed is more important than to be beside the patient. Dermatology, as you are going to speak now, will open for you a lot of knowledge. Of course, you are building your knowledge now. I advised you not for pizza alone, for every specialty you are going to do, try to make a folder. If you attend the case, try your colleague now giving various references out of campus. So you can work for that. You can bring a new article in up to date or in BMG or whatever. Okay, and try to make a folder one by one. A folder for media, folder for ONG, for surgery, for whatever. And with time, it will be your wealth. Okay, because medicine needs knowledge and needs also wise manner to arrange this knowledge so you can come to the conclusion. Okay, let us start by first presentation. Who will be?
Me, Doctor.
Okay, so start, Akmal. Everyone try to mute his microphone so Akmal can concentrate, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah Rabbil Alamin wa afdalus salati wa atammu taslim Sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim wa la hawla wa la quwwata illa billahil aliyyil azim. So first of all, I would like to express my gratitude to Dr. Mossad for his willingness to attend this seminar. Thank you, Doctor. And to my colleague, my friends, thank you for your spirit. Thank you for your prayers. May Allah bless all of you. So as we all know today, we'll be having dermatology seminar. Okay, and this seminar will be discussing on 4 topics. The first topics will be discussed and addressed by me on hemangioma, followed by atopic dermatitis by Maria Abu Samah. Third on list will be addressed by Nurul Sufiana on scabies, and the last one on Stevens-Johnson syndrome by Wan Umaira. Okay, are you ready? Yes, you must be ready. Let's go. So my name is Muhammad Akmal bin Muhammad Hisham. Metric number 1817435 will be addressing and discussing with you on hemangiomas. My friends, the Maulidur Rasul is not the only day for us to do our prayers and salam to the Prophet sallallahu alaihi wasallam. He is not our Prophet only on Maulidur Rasul. He is our Prophet today, he is our Prophet tomorrow, and he is our Prophet forever. Let us all spend 3 seconds to send our salam to Prophet sallallahu alaihi wasallam. Allahumma salli ala Muhammad wa ala ali Sayyidina Muhammad. Okay, we proceed. These are my outline for my presentation. We'll be starting and discussing on definition, followed by epidemiology and pathogenesis. Next on list is clinical cause, the clinical subtypes and features, the complication, investigation, management and treatment, and the last one, the prognosis. So as you can see in this picture, this is an image of hemangioma. This is an image of hemangioma, okay, so that you can get a clue on what I'll be talking about today. Okay, first of all, when we are talking about hemangioma, we cannot run from discussing about the definition. So the term hemangioma itself is derived from the Greco-Latin tradition. So if you are well versed in Greco-Latin tradition, you can get a clear understanding from the term itself. Hema, what is meant by hema, angio and oma? These 3 words constitute in the term, in the word hemangioma. Hema is meant by blood, angio is meant by vessels, and oma is meant by tumor, benign tumor. So in your mind, you know that hemangioma is a benign tumor that has something to do with the blood vessel. Okay, but in a proper manner, in proper words, hemangioma is meant by a benign tumor that arises from the proliferation of the vascular endothelium, and it is characterized by 2 phases. What are they? They are the growth phase and the involutional phase. What is meant by involutional phase is that the phase where it regresses, the phase where it shrinks, the phase where it recovers. Okay, and because it is benign, it rarely transforms into malignant. So don't worry. Okay, on your physical presentation, on your physical eye, it is characterized by a bright red birthmark that shows up at birth or in the 1st or 2nd week of life. Some baby may present with hemangioma during their birth. Some may not, but later on at the 1st week, at the 2nd week of life, the hemangioma slowly appears. Okay. For the epidemiology, all you have to take note is that 1 out of 10 babies have hemangioma. So it is quite uncommon, but it is not really common. You get it right? And they are more common appear to girls, more common in this 4 group of people. They are girls, premature babies, low birth weight babies, and multiple birth babies. So if you are one of them, you might have hemangioma during your childhood. And the most important thing that you have to take note is that since it is a benign tumor, not all benign tumor, because it is a benign tumor, the word tumor itself is quite a taboo word because some people think that people with tumor might be inherited. But don't worry not, because hemangioma is not inherited. So if you have hemangioma, not necessarily your child will have hemangioma. Okay, the pathogenesis. So according to my references, almost all of them does not explain about the pathogenesis, but all of them suggest that hypoxia might play an important role in causing hemangioma. How? First of all, you need to understand what is meant by hypoxia. What is meant by hypoxia? Hypoxia is meant by diminished in oxygen supply to the tissue. Diminished in oxygen supply to the tissue. But how then it can cause hemangioma? So, I give you a situation. You have a hypoxic tissue. Now the tissue is diminished, has low level of oxygen. So what can we do to repair this tissue? We need more level of oxygen. How can we transport more oxygen? We need more blood. How can we transport blood? We need more vessels. We need more blood vessels, right? And for that particular reason, to increase the amount, the blood vessel, we need hypoxia inducible factor 1 alpha. So when there is hypoxia, it will trigger the release of hypoxia inducible factor 1 alpha. What are they? They are in the list that I mentioned below, which are the vascular endothelial growth factor, VEGF, the GLUT1, and the insulin-like growth factor 2. There are many more, but these are mentioned in my references. So I only take it as it is. Okay, and after that, when there is proliferation of vascular endothelium, more blood vessel, what will happen? More blood will be transported. When there is blood, more blood will be transported. More blood means that more oxygen, especially if the vessel is involving the arteries and the arterioles. More blood will be transported and more oxygen. More oxygen meaning that it can repair the hypoxic tissue. So in other words, to conclude the pathogenesis of hypoxia is a homeostatic response, a homeostatic attempt to repair the hypoxic tissue. Okay, you get it right? Let's go. Next, the clinical cause. Okay, for the clinical cause, you need to focus on the graph, on this graph. Okay, this graph. As you can see, until the age of 4 months, the hemangioma will grow rapidly. But after 4 months to 12 months, it will grow slowly. After 18 months, at the age of 18 months, there will be slow involution. Means that the hemangioma will regress slowly, will shrink slowly. Okay, and on the involution phase, like I mentioned just now, it is characterized by growth phase and involution phase. On involution phase, by the age of 5 years old, it is predicted at least 50% of the hemangioma has shrunk. And at the age of 9 years old, at least 90% of the hemangioma has involuted. 90% of them has involuted. And up to 20 to 40% of hemangioma will leave residual change on the skin. The residual change can be redundant skin, can be scarring, can be fibrofatty tissue. The list will be mentioned at the end of the presentation at the prognosis. Okay, and how can we know that the hemangioma is shrinking? So it is characterized to know the hemangioma is shrinking, is recovering, is regressing. It is characterized by development of central pale gray at the hemangioma. Okay. Now, let's go to the clinical subtype. There are few types of hemangioma. It is quite different according to my references. Some group them as two types, some group them as 3 types, and some group them as 4 types. But I take Malaysian classification. There are 4 types of hemangioma. The first one is superficial hemangioma. Second one is the deep hemangioma. Third one is the mixed hemangioma, and the fourth one is the multiple neonatal hemangiomatosis. Okay, for the first one, this first subtype is the superficial hemangioma. This kind of hemangioma is the most common form of hemangioma, as it constitutes about 50 to 60% of all cases. It is also known as the strawberry or capillary hemangioma. As you can see in this picture, this hemangioma is very bright papule and very sharply circumscribed. And it is compressible, meaning that it is quite squishy. But if you are to squish it, don't squish it too much because it can ulcerate, it can rupture. Okay, it is very fragile over here. And it can reach maximum size by the age of 6 to 8 months. Okay, very red, very beautifully circumscribed lesion. Okay, the second type of hemangioma is the deep hemangioma. Unlike the the superficial hemangioma, deep hemangioma doesn't appear red. Instead, it appears slightly bluish discoloration on the skin. You can see over here, there is bluish discoloration, bluish discoloration. Why? Because the hemangioma itself is situated beneath the skin. The superficial hemangioma just now, the hemangioma protrude to beyond the skin. So it is visible. You can clearly see the red color of the blood under this the color of the blood on the hemangioma. While the deep hemangioma, you cannot see it clearly because it is deep under the skin. It is quite soft and warm mass and more diffuse and less defined. However, it can grow up to 12 and 14 months. Okay, this is, you can see, right? Bluish discoloration. In Malay, some people may call it as bengkak, lebam. But it is actually not bengkak or lebam. It is hemangioma. Okay, the third type of hemangioma is the mixed hemangioma, where both superficial and deep characteristics are present. Like I mentioned just now, you can see there is red appearing papule and underlies with bluish discoloration beneath this red papule, meaning that there is deep hemangioma below the superficial hemangioma. Okay, this hemangioma constitute about 25 to 35% of the cases. Okay, the fourth type of hemangioma. The fourth type of hemangioma is quite devastating. It is known as the multiple neonatal hemangiomatosis, where it consists of multiple small lesions that range from few millimeters to 1 to 2 centimeters. You can see, right? Unlike the three type of hemangioma before, the three type of hemangioma before is quite solitary lesion. If you can see it on one side only, but in this case, in multiple neonatal hemangiomatosis, the hematoma can be seen all over the body. You can see it on the face. You can see it on the body, on the hands, the back, the pelvis, and even the legs. So it is spread all over the body. Okay. Wait, there is something technical problem. Okay, this is the illustration for the hemangioma. Okay, the superficial hemangioma and the deep hemangioma. As you can see in the superficial hemangioma, the hemangioma itself protrude the skin. So that is the reason why we can see the hemangioma clearly, very bright red papule. However, in the deep hemangioma, the hemangioma itself doesn't protrude the skin. So it remains under the skin. That's why we can only see the bluish discoloration. Okay, on clinical features, almost 50% of hemangioma is located in the head and neck region, and most of them are solitary lesion. However, if there is more than one lesion, there might be increased risk of getting visceral hemangioma, can be liver hemangioma and more. About 1% of the hemangioma can be life-threatening, and 10% can cause impairment, functional impairment due to their location. For example, there is hemangioma at the neck, deep hemangioma in the neck. What will happen to the breathing of the baby? Will be compromised, isn't it? So it depends on the site of the hemangioma. The age of the patient also play an important role to determine whether it is life-threatening or not. Okay. Now the complication. Hemangioma can present with can cause some complication. Dysentery is the most common. However, the most common complication among all is the ulceration. It is most frequently seen. And you know that when there is ulceration, there will be increased risk of getting infection and hemorrhage, right? Okay, the second one is the large segmental hemangioma. The large segmental hemangioma can be an indication that there is underlying malformation of blood vessels, heart, or nervous system. And this kind of complication is seen in the face and pelvis syndrome. What are the face and pelvis syndrome? I will show you the picture afterwards. And the third complication is the Tasabak-Merritt phenomena. Tasabak-Merritt phenomena is a phenomena that is characterized by severe thrombocytopenia that result from platelet trapping within a vascular tumor. Okay, and this is a very, very, very life-threatening condition. So So if you are to diagnose, if you see the Kasabak-Merit phenomena, I will show the picture afterwards. Please take immediate action. This patient require immediate attention. Okay, so the face syndrome and the pelvis syndrome. What are they? Actually, the word face itself, the PHACE and the PELVIS is actually the collection, the acronym for the complication of the syndrome. For example, the the PHACE syndrome is actually a group of complication that is happening on the face. Okay, and they are the posterior fossa structural brain abnormalities, the complication, and the hemangioma. Patient who can present with hemangioma on the face, head and neck. There might be arterial lesion, cardiac anomalies, eye abnormalities. You can see over here. This is face syndrome. Okay. And for the pelvis syndrome, it is actually the same. It is an acronym, but it is quite different because it is perineal hemangioma with any of the following. So it can be external genitalia malformation, it can be lipomyelomeningocele, it can be vesicorenal abnormalities, it can be imperforate anus, and it can be skin bag. So this picture is the pelvis syndrome. This picture is pelvis syndrome. So quite pity, isn't it? Okay, next. This image is the image of the Kasabak-Merit phenomena. Okay, severe thrombocytopenia that result from the trapping of platelet within a vascular tumor. So if you are to diagnose this patient, you need to do platelet count because only that you can confirm that this is a Kasabak-Merit phenomena. This is a life-threatening condition. So the patient really need immediate attention because thrombocytopenia, we know that when there is thrombocytopenia, if anything happen to the baby, injured or get wound, the wound might heal slowly, right? So please take immediate action if you are to see, you are to observe or you are to diagnose the patient is having Kasabak-Merit phenomena. Okay, these are the other complications according to special sites. For example, if the hemangioma is in blood distribution, hemangioma of blood distribution, there might be area obstruction if there is involvement of upper airway and subglottic region. If the hemangioma is at the eye, around the eye, involving the side of the eye, patient might present with amblyopia. Patient might present with strabismus. Patient even might present with astigmatism. And if the hemangioma is at the lumbar area, the patient might have imperforate anus, renal anomalies, or even sacral anomalies. Okay, investigation. For your information, almost up to 90%, 95% of diagnosis can be made based on the history and the physical examination. Why? Because hemangioma is a very typical appearing vascular tumor. When you see it, you know this is hemangioma. You can see it with your naked eye and you can conclude that this is hemangioma. So you can suggest the first thing that crossed in your mind is this is hemangioma. And from the history itself, the history of the baby, the history of lesion might the history of lesion seen at birth or shortly after birth because as we know, hemangioma is characterized by growth and proliferation. Growth and evolution. The growth itself happens at early infancy until the rapid growth until the age of 4 months, right? So we can conclude that, okay, this is a hemangioma. You don't really require any investigation to conclude, to diagnose hemangioma. Okay, but if you are to do laboratory investigation, what you can do is you need to measure the level of markers of hemangioma proliferation and differentiation. Why? Because this factor, the hypoxia inducible factor 1 alpha, like I mentioned in the pathogenesis just now, play a very vital role in causing hemangioma. So you need to measure that level, the level of that mediators, to conclude that this patient might having hemangioma. Some of them, you can measure the serum vascular endothelial growth factor, you can measure the urinary beta fibroblast growth factor, and even matrix metalloproteinases. In special cases such as the Kasabak-Merit phenomena, you need to do platelet count. If there is thrombocytopenia, now we can conclude that this patient is having Kasabak-Merit phenomena and need immediate intervention. Okay, management and treatment. If you are to treat when treating a patient with hemangioma, first of all, you need to evaluate the hemangioma, whether it is low risk or no risk or high risk hemangioma. What are they? The low risk hemangioma is hemangioma that is small and does not cause functional impairment and less likely to leave any permanent disfigurement. For the high risk hemangioma, it is a hemangioma that is large, prognostically poor location, and most likely to leave permanent disfigurement and causing a functional impairment, or it can involve extracutaneous structure. So you need to evaluate whether this kind of hemangioma is the low risk or high risk. If low risk hemangioma, most of the time, low risk hemangioma does not require any treatment. Okay, and we usually use wait and watch policy. Wait and watch policy because we know that hemangioma will shrink and regress by time, right? Like I mentioned in the clinical course, by the age of 9 years old, it is predicted that at least 90% of the hemangioma has shrink. Okay, and we give them with low risk hemangioma, we give patient and parent education on what to do and what not to do. So active intervention, active non-intervention is recommended in order to recognize those that may require treatment quickly. And if you are to do treatment on this patient, please make individual customization because not all patient requires the same treatment regimen, the same medication. Okay, some may require that, while others might not require that. And you need to evaluate that. You need to evaluate the individual customization according to their age. Please observe their age. Is there any complication and the site of the lesion? Okay. And these are the medication that you can give to the patient with hemangioma. The first of all is propranolol. However, if you are to give propranolol, you need to observe for the side effect that is mentioned below. Okay, the hypotension, bradycardia, hypoglycemia, bronchospasm, sleep disturbances, diarrhea, and even hyperkalemia. Just imagine this side effect, if it happens in adult, it is quite devastating. Now it is happening, if it happened to the children, the infant, it will be much more devastating. Okay, so you need to observe whether you need to observe and evaluate the risk of giving the medication. Next on list, you can give them prednisolone, the corticosteroid. Okay, however, you need to watch for any growth retardation, hypertension, insulin resistance, and even immunosuppression. Immunosuppression is is very, the children itself is already immunosuppressed. Now you are giving a drug that can cause immunosuppression, so you need to be careful. Okay. However, if the prednisolone, the corticosteroid, does not give any response, you can give them interferon alpha. Okay, but the only side effect that you need to be worried about interferon alpha is that it can cause neurotoxicity. So a part of using interferon alpha, you can use vincristine. Okay, these are the treatment regimen. Last one, surgical treatment. Okay, if you are to do surgical treatment to the patient, you need to evaluate, you need to observe, evaluate, and measure the risk and benefit. Is it okay to do surgery on this patient? Some patient may need surgery, some patient might not need surgery. So please evaluate carefully. And you have to note that surgical treatment is good to be done if the hemangioma is a pedunculated hemangioma or the hemangioma that can cause functional impairment. Otherwise, most of patient does not require any surgical treatment. And for information also, surgical treatment of hemangioma is usually done to repair residual cosmetic deformities, repairing the scars, repairing the redundant skin, fibrofatty tissue. And the method of surgical treatment that is used for hemangioma is the laser surgery and surgical incision. Okay, prognosis. This quite important part. All you have to take note is that if the hemangioma is uncomplicated hemangioma, the prognosis will be good. Inshallah, the prognosis will be good. And skin changes can be observed in 50% of the case. And the skin changes that you can observe in the patient might be dyspigmentation, telangiectasia, atrophy, fibrofatty tissue, redundant skin, and scarring. Okay. However, if the hemangioma is complicated hemangioma, the prognosis might be less less good. It is not bad, but it is might be less good in comparison to uncomplicated infantile hemangioma. I think that's all for my part. Okay, these are my references. Most of them are taken from UM and the periodic protocol. Okay, these are my references, and thank you. Any questions?
I have a question.
Yes.
Since you said that most of the cases don't go into complicated, so do we categorize them as curative or not?
Can you repeat the question?
You mentioned how most of the cases don't go into complication. So can we label this case as like curative or not for this condition? Is it curative?
Okay. According to my reading, according to my references, it is curative. But however, the curative doesn't mean that it doesn't leave any defect. The curative itself will leave some defect. The complication, the afterwards effect is that the patient might have a cosmetic defect on their faces or the site that is having hemangioma. Okay. However, it is curative.
Understood. Thank you.
I have a question.
Okay. Yes, Ashraf.
Okay, so based on the classification, you said that hemangioma can be divided into 4, which is the superficial, deep, mixed neonatal hemangiomatosis, and the last one is it right?
Pardon?
There is 4 classification for hemangioma.
Okay.
So in complication, you mentioned also visceral and large segmental, and there is pedunculated. So is it fall in what subtype?
Okay, for the pedunculated hemangioma, it is mostly seen, it is a subtype under the superficial hemangioma. The pedunculated. But for the visceral hemangioma is quite different because the hemangioma itself is occurring in the organ, in the visceral, with the viscera. So it is not characterized it is not seen in the skin. However, it is a type of hemangioma also. Pardon?
The last one, large segmental.
Oh, large segmental hemangioma is a kind. It depends. Most of them are superficial hemangioma, but only that it is segmented and it is very large, present at the face, present at the pelvis. If it is regards with the face or pelvis syndrome.
Thank you.
Any question? If no question, I end my presentation.
Thank you, Akmal. I will leave my comment to the end, okay? Who is our second presentation?
My name is Marvin binti Abusama. I present about atopic dermatitis. So this is my outline for presentation. From introduction to prognosis.
The voice is slow.
Hello, is it more clear? Hello.
Still tak dengar sangat Maria.
Is it clear? Is it more clear now?
Yes.
Okay. So this is my outline presentation from introduction to prognosis. So for the introduction, what is atopic dermatitis? Atopic dermatitis, according to pediatric protocol, is a chronic inflammatory itchy skin condition that usually develops in early childhood and follows a remitting and relapsing course. It often has a genetic component, and it will lead to the breakdown of the skin barrier, making the skin susceptible to trigger factors, including irritants and allergens, which can make the eczema worse. So by words, atopic means that it has genetic factors to develop allergy, and while dermatitis is the inflammation of skin. So atopic dermatitis is also known as atopic eczema. For the epidemiology, the prevalence of AD, atopic dermatitis, is in 15 to 30% of children, and it also occurs in 2 to 10% of adults. It affects all races, and the age of the onset, usually 85% of patients with AD will have AD the onset in the first year of life, while 95% of them will have onset before 5 years old. The sex preference male to female ratio is 1 to 1.4. So it's more preferable to in female. For the etiology, there are three causes that that cause atopic dermatitis, which is genetic predisposition, the trigger genetic predisposition that cause skin barrier dysfunction, and triggering factors such as allergens, infections, irritants, and so on, and also immunological abnormalities. However, the triggering factors are different for each person. Some person may have allergy to food, but some may not, and so for the other triggering factors. For the pathogenesis, the genetic predisposition, the patient usually have filaggrin mutations, which is the component of epidermal barrier. So when the mutation of filaggrin happens, the epidermal barrier becomes dysfunction, and the skin becomes dry and cracked. This will ease the entry of antigens, and when the antigens enter, the immune system will produce the inflammatory cytokines, and this will lead to inflammation process, and leads to redness, swelling, and itchiness. So when there is itchiness, the patient tends to scratch more, and this will lead to the skin to be more cracked, and the cycle repeats. For the triggering factors, as I said before, some factors are triggered for some, but some are not. So for the environment, the temperature, the prolonged exposure to low humidity will cause the dryness of the skin. The use of soaps that are neutral or alkaline, soaps or other irritants like detergents will change the pH of the skin. And while the psychological or emotional stress can aggravate the skin permeability function. For immunological abnormalities, AD is type 1 hypersensitivity. So when the patient is exposed to allergens, the allergens enter the skin barrier. The allergens will be presented by Th2 cells to B cells, and B cells will produce IgE, and IgE will cause mast cells to produce more histamine that will react to the nerve ending of our skin, and that will cause more itchiness. So when the itchiness occur, and the cycle repeats again. For the clinical manifestation, there are two cardinal features of atopic dermatitis, which is intense pruritus and also cutaneous reactivity. While for the skin lesion, there are, according to Nelson textbook, there are three types of skin lesion, which is acute, subacute, and chronic. So for acute skin lesions, usually it is intensely pruritic with erythematous papules, like in the picture. For subacute, it is erythematous, excoriated, and scaling papules. For chronic, there is lichenification and fibrotic papules. For acute, usually a patient, AD patient, infant patient will present with acute skin lesion, while for older patients, older children will present with chronic skin lesions. However, the patient present with chronic skin lesions may also have other type of skin lesions. The three types occur in one person at the same time, usually in older children. For the distribution of the lesions, for infants, usually it involves the face and scalp. Face and scalp is the predominant place, and the trunk may involve sometimes. In older children, usually it occur at the skin flexures, such as the cubital and popliteal fossae, and also frictional areas, such as neck, wrist, and ankles. To diagnose atopic dermatitis, it is diagnosed on the basis of three major features, and while the minor features reinforce the diagnosis of AD. And this is according to pediatric protocols. The major features, we must have three major features to diagnose AD, which is pruritus, typical morphology and distribution, chronic or chronically relapsing dermatitis, and also personal or family history of atopy. While the less specific features or the minor is xerosis, preauricular fissures, ichthyosis, IgE reactivity, and or foot dermatitis, cheilitis, scalp dermatitis, susceptibility to cutaneous infection, and perifollicular accentuation. So this is the picture. Xerosis. Xerosis is means the abnormally dry skin. The scalp dermatitis, the inflammation of the skin at the scalp, the cheilitis, which is the inflammation of the lips, and also ichthyosis. Ichthyosis is the rough, thick, and scaly skin. There are many differential diagnoses of atopic dermatitis. This is from Nelson textbook. It can be other types of dermatitis, infectious skin disease, congenital immunodeficiency, or nutritional deficiency metabolic disorders. I will explain a little bit about other types of dermatitis, especially those are common in infants or children. For seborrheic dermatitis, it is common in infants, but the difference is that it is salmon red greasy scaly lesions, and it often involves in napkin area. In AD, the napkin area usually spared. For nummular dermatitis usually no itch, but for AD, must have itch to diagnose AD. And then for irritant contact dermatitis, it is acute to chronic eczematous lesions, mostly confined to the site of exposure, and has history of locally applied irritants. Has history of applied irritants, and it might coexist with AD. For allergic contact dermatitis, it is eczematous rash with maximum expression at sites of direct exposure, but might spread and has history of locally applied irritants, and also might coexist with AD. So for irritant contact and allergic contact, it has history of locally applied irritant, and it can also coexist with AD. And this is the other differential diagnosis. So for investigation, usually to diagnose AD, we don't need investigation because diagnosis is made clinically. But if it is to be made, usually we will do blood test, and it will show elevated total plasma IgE level, because the hypersensitivity, and also peripheral blood eosinophilia. We can also do skin prick test or the radioallergosorbent test to identify the type of allergen that the patient is sensitive on. Further complication, the patient may develop exfoliative dermatitis due to superinfection. Superinfection usually caused by toxin-producing bacteria like Staphylococcus aureus or herpes simplex virus. It can also due to inappropriate therapy, such as withdrawal of systemic glucocorticoids to control the severe atopic dermatitis. Other complications is like eczema herpeticum, keratoconus, which is conical deformity of the cornea, and it is due to chronic rubbing of the eyes in patients with AD. Also cataracts due to extensive use of glucocorticoids, especially around the eyes, and also atopic keratoconjunctivitis. For that management, this is from pediatric protocols. The management is different based on the physical severity. For example, if the patient is clear, means have normal skin and no active eczema, we will only advise or give emollients. For the mild, which is there are areas of dry skin and infrequent itching, and also small areas of redness, we will give emollients and plus the mild potency corticosteroids. For moderate, we'll also give wet wraps and also tacrolimus. So tacrolimus is an immunosuppressive drug. For severe, we will add the systemic therapy and also phototherapy. So I'll explain more on the management. So bath and emollients. So the bath soothes the itching and also removes the crusting. The lukewarm and it is advised to do lukewarm and also limited to only 10 minutes duration of the bath, and also avoid soaps in the bath. We can use soap substitute such as aqueous cream or emulsifying ointment. And the emollients are best applied after bath. And use the unperfumed emollients such as aqueous cream or Vaseline. For the topical corticosteroids, the choice depends on the balance of efficacy and side effects. It should be applied once or twice daily, and also avoid the sudden discontinuation to prevent the rebound phenomenon. It is advised to use milder steroids for face, flexures, and scalps. So in this table, there is a number of FTU required. FTU is the fingertip required for the body areas. For example, for one hand, so only use one FTU. For one leg, use 6 FTU. And the steroid, this is the steroid potency for the mild topical steroid, example is hydrocortisone cream or ointment or 1% ointment. And moderate is betamethasone, Eumovit. Potent is betamethasone and Elomate, while super potent is Dermovit. So the more potent the steroid is, the more side effects it has. So the choice depends on the balance of the efficacy and side effects. For the systemic therapy, there are 3 components of systemic therapy, which is to relieve the pruritus, the treatment of secondary infection, also treatment of refractory cases. For the relief of pruritus, we will offer a 1-month trial of non-sedating antihistamine. If it is successful, we will advise to continue when the system persists, and it will need to review every 3 months. For the treatment of secondary infection, it is needed if the patient have the extensive infection, usually caused by Staphylococcus aureus. So we will give oral chlorhexidine 15 milligram orally. But if the extensive infection is caused by herpes simplex virus, which leads to complication like eczema herpeticum, so we give antiviral like acyclovir. And for the treatment of refractory cases, usually we refer to dermatologists. Other measures for the management of atopic dermatitis is that we advise the patient to avoid woolen toys, clothes, and bedding, reduce the use of detergents, and not giving BCG until the skin improves, and also do swimming, and also avoid aggravating or triggering factors. For the prognosis of AD, the prognosis is good. AD is generally tends to be more severe and persistent in young children. The periods of remission will occur more frequently when the patient is older, and the relapse of the disease in adults can occur and commonly manifest as face or hand dermatitis. 40 to 60% of patients affected during infancy will have spontaneous resolution after 5 years old, and 84% of children will outgrow their AD by adolescence. So that's all for me. This is my references. Thank you.
Okay. Do you have any question?
I have a question. For the
Yes.
other measures that you said earlier, like you mentioned swimming. Is it to avoid swimming or to do swimming?
To do swimming.
Why would we wanna encourage them to swimming? I don't
It's like the bath, but also it's like the bath, which can increase the moisture of skin, but it has also limited time. But like, can you hear?
Oh, okay, got it. Thank you so much.
Any other question?
Sorry, doctor, we can't hear you clearly.
Okay, so just remembering you for the first presentation. The most important point for the eczema, how to prevent it is exclusive breastfeeding. it will decrease the incidence of atopic dermatitis and eczema, but by about 50%. So we need to add one more slide about the importance of 50%. Okay, so it is very important to consider the importance of breastfeeding and decrease all atopic diseases, especially eczema. The most important point also is to decrease the eczema herpeticum. Anyone with severe, if any herpes simplex, mustn't deal with the patient with eczema because it will be life-threatening one. If you are able to add one slide about eczema herpeticum, it will be very important. Okay, skin distribution, of course, will guide you about the age. Okay, but for all dermatology, can you hear me?
Yes.
Is my voice clear now?
Yes.
Okay. So the most, okay. Am I clear?
Yes, doctor.
Yeah, the most important for any cutaneous case to have also flow for examination. I mean by the flow here, how to come to the diagnosis by a systematic manner. Okay, so number one, I will ask myself, where is the rash? Is it generalized or localized? Okay, number two, what is the characteristic of the rash? Is it macule or papule or maculopapular? Is it vesicles? Is it hemangioma? So I must be able to define the number one, the lesion which I have. What is the distribution of that lesion? Okay, is it symmetrical or asymmetrical like that? Number two, I will try to comment about the skin appendages. I mean the skin appendages is the hair, the nail, the eyelash. All this is considered is a part of the skin, and it can guide you, like some changes in the nail can guide you, and like that. It is very important. Okay, for the hair, for systemic lupus or discoid lupus, you can find some changes in the hair. So it is very, very important. Okay. The third one, is there any characteristic skin? It means like systemic lupus or other, or atopic dermatitis or ichthyosis or like that. All this will guide us. So we are examining whole the skin. We are commenting a skin appendages, and then I will ask myself, is it a part of systemic disease or it is just skin? Because if I feel the patient in front of me has a problem with like malar flush, so I will go ahead and check for another problem with the systemic lupus. Okay, this is a very important point. Sometimes we need to check also about the deep structure, like neurocutaneous syndrome. I have now, you will speak about that. If I found anything in the skin, I must go to the other system to check hydrocephalus, is there any big sized head, is there any complication, is there any tumor? Hemangioma, sometimes if we are worried, we need to do some CT scan or ultrasound to detect any organ like the brain or like that. And at the end, we must check for the complication. I will now come to the by examination to the diagnosis and the localization, and is it a part of systemic or it is just an isolated skin problem, and then I will ask myself what is the possible complication and is it present or not. This is for every patient, for every disease, not only dermatology, but dermatology, it needs to be frank for you, how you are dealing with that. Hoping, inshallah, if we are able to present one case of dermatology in our presentation after that, okay? So it will open for us a lot of things, like a patient with dengue fever. You will find skin manifestation. What is the name of that? You must know, because we have some endemic diseases. We must be able to, we must know all the details about it, okay? For any investigation, a good point which Akmal speak about is important to have rationale for investigation. We are not doing all investigation for everyone, okay? You must have rationale. You are not working by blanket investigation. Also, speaking about patient customization is very important, so that plastic surgery may be included with us, especially if it is a female or like that. Okay, good. Let us continue for the next presentation.
Hello, can you guys see my screen?
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Sufyana, and now I would like to talk about scabies. So here is the outline of my presentation. I will talk about what scabies is, the epidemiology, etiology, risk factor, transmission, life cycle of the mite causing the scabies, the complication, the clinical manifestation, the case study related to scabies, the complication, management, and treatment of the scabies. Okay, so according to pediatric protocols, scabies is defined as infestation that is caused by the mite named Sarcoptes scabies, and this scabies is a highly contagious disease. Any part of the body may be affected, and the transmission of the scabies is by skin-to-skin contact. Scabies is also referred to as 7-year itch, where imply the irritating and contagious complaint of long duration. Okay, next is the epidemiology of the scabies. Scabies is a common infestation that can affect individuals of any age and socioeconomic status. According to UpToDate, the worldwide prevalence is estimated to be 100 million people, with wide variation of prevalence with different geographical regions. Crowded condition, which allows skin-to-skin contact with many people, can increase the risk of scabies infestation. An epidemic can also occur in institutional settings such as long-term care facilities and prison. Next is in Malaysia, scabies infestation is high among children and teenagers. Based on a survey done in a welfare home in Pulau Pinang among 120 children, infestation rates were the highest in the 1 to 12 years age group. And this scabies is more commonly seen in boys than girls. The overall prevalence rate for this scabies in the welfare home survey was 31%. Next is the etiology. Human scabies is caused by SCB hominis. It is an obligate human parasite in which its survival is entirely dependent on its host, which is human. It is a whitish brown mite and has 8 legs. Female mites are usually larger. Female mites are larger than male, measure approximately 0.1 millimeter in length. Usually after mating, female mites burrow into the epidermis, lay 2 to 3 eggs per day before dying after 4 to 6 weeks. Prevalent rates for scabies are higher in children. Hence, presence of many young children in the household increase the risk for getting affected. While in adults, scabies is usually sexually acquired. Other than that, person with immunocompromised conditions such as post-transplantation, HIV disease, old age are particularly at particular risk for crusted variant. Poor hygiene habits such as sharing towels and clothes and irregular use of shower can also increase the risk. So, as I mentioned before, scabies is usually acquired from skin to skin transmission with another individual who has scabies. It can also be sexually transmitted, usually in adult, and it is also sometimes transmitted via infested clothes and bedding. Okay. The incubation period for those who without previous exposure is 2 to 6 weeks, while for those who have previous exposure is 1 to 5 days of re-exposure of the disease. Next is the life cycle. The subcortis scabies undergoes 4 stages in its life cycle, which is the egg, larva, nymph, and adult. So as the adult female burrow under the skin, they will deposit 2 to 3 eggs per day, and the eggs are oval and hatch in 3 to 4 days, releasing larva. So the larva will migrate to the skin surface and burrow into stratum corneum to construct almost invisible short burrow called molting pouch. So this is what we call as molting pouch. The larva can last about 2 to 4 days. After the larva molt, it will reside in nymph, and this nymph will molt again into a slightly larger nymph before molting into adult. In the molting pouch, larva and nymph may often be found. Okay, mating occurs after the active male penetrates the molting pouch of the adult female. Mating takes place only once and leave the female fertile for the rest of her life. Impregnated female will live after mating will leave their molting pouches and wander on the surface of the skin until they found a suitable site for a permanent burrow. When the impregnated female might find suitable location, it begins serpentine burrow, which is the characteristic of the scabies. Then the adult female will lay eggs in the process. Okay. So here is the common sites of the scabies. The pink highlight is the areas represent the common site where the rashes of the scabies may occur. And these are the lengthy explanation for the life cycle of the scabies, for the subcortis scabies. Okay, now we move into clinical presentation. So clinical presentation of scabies has many variants and varies depending on few factors such as age of the patient, duration of infestation, and immune status of the patient. But the main symptom usually is severe paroxysmal itching, which is the main hallmark of scabies infestation. Other than that, history of each among family members within the same period also shows symptoms of scabies. So the first variant of scabies is the classical scabies, which is the most common variant of scabies. It presents with thread-like burrow lesion, but this may not be seen in infants because in infants, bullae and pustules are more common. The palm, sole, and scalp are often affected in classical scabies. In adult, preferred site are usually the anterior axillary fold, nipple area, umbilical area, interdigital fold, wrist, elbow, genital area, and feet. Head, neck, and palms and sole are usually spared in adult, while in infant and young children, lesions are more common on the face, scalp, neck, palms, and sole. Okay, so this is common site for scabies. So the first picture shows the thread-like barrow lesion. The second picture shows the lesion of both hands and the web of the finger. The third one shows lesion. The third one shows lesion on the soles, and the last one is the diffuse scabies on an infant. The next variant is the nodular scabies. It is a less common variant of scabies. It occurs in 7 to 10% of patients with scabies and particularly occur in young children. It presents with red-brown nodules most often located in the covered areas such as axilla, genitals, and groin. Next one is the crusted scabies, or also called as Norwegian scabies. It is an uncommon form of scabies and it is highly contagious because it has a huge number of mite infestation. It occurs mainly in individuals with mentally and physically debilitated. Also occurs in patients with poor cutaneous sensations such as leprosy and spina bifida. Also in immunosuppressed patients such as HIV patients. Pruritus in crusted scabies may be minimal or absent, and crusted scabies is characterized by diffuse hyperkeratosis, which are particularly severe on the hands, under fingernails, ears, trunks, and extremities. The infestation is also often accompanied by generalized lymphadenopathy. So these are the pictures of hyperkeratosis and crusting. The nails in crusted scabies can also become thickened and dystrophic. So now here I include a case study on scabies. A girl aged 11 years old came with her mother with the chief complaint of discomfort of full body itchiness since 2 weeks ago. According to the mother, itchiness started from her finger first, which widespread to her wrist, armpits, and back within the time frame of 1 week. She also complained of itchiness in her lower extremities. The girl experienced such for the first time and had never consulted a doctor, assuming that it will disappear by itself. Furthermore, she said that itchiness worsened at nights and her sleep was ruined by intense pruritus for the past 2 weeks. In these 2 weeks, the complaint did not reduce or subside. It intensified until her daily routine was affected. History of pyrexia was denied. Her mother applied a traditional cream to the affected area, but the symptoms did not show any improvement. According to the girl, both her brothers are experiencing the same complaint, and apparently she has a history of sharing the same room and bed with both her brothers. So on physical examination, her vital signs appear to be normal with blood pressure of 110 over 70 millimeter mercury, respiratory rate of 80 times per minute, pulse rate of 72 times per minute, and axillary temperature of 36.3 degrees Celsius. The girl appear well nourished with a body mass index of 20, and in further general examination, everything appear normal. And according to the dermatological finding, the itchiness was limited bilaterally between her fingers, wrist, palm, armpit, back, and chest. There was multiple erythematous papule, round shape with well-defined border, with no scale. The papules also appear in multiple spherical vesicle with erosion that has already healed and crusted. There were also a few serpiginous papules that appear whitish to grayish color and has a thread-like elevated line on her right hand. So from the history, taking a physical findings, 3 differential diagnoses were raised, named scabies, pediculosis corporis, and prurigo. So the diagnosis of scabies comes based on clinical examination. So basically, diagnosis of scabies is made on clinical ground with the history of itching and the characteristic of lesion. Although burrows are the indicative characteristic, but the burrow can be hard to identify because of the scratching that may cause secondary bacterial infection. Itching in other family members also is helpful clinical indicators. And for confirming scabies, microscopic examination can be done by scraping skin from the lesion to identify the mite eggs and the mite feces. Complication of the scabies include peeling away of skin due to the intense scratching, and also there may be a secondary eczematous or urticaria reaction. This secondary eczematous and urticaria reaction can mask the true diagnosis of scabies, and also secondary infection can also occur due to the scratching. So next is the management of the scabies patient. Most importantly, doctors should educate parents and give clear written information on applying the treatment. And not only the attending patient should be treated, but everyone in the household and their close contact should be treated, because scabies is transmitted by skin to skin contact. So obviously that all of the people in the household may also be affected. Clothes and bedding need to be washed in hot water, as hot boiling water can kill parasites, and clothing that cannot be washed may be stored in a sealed plastic bag for 3 days, because scabies mite generally does not survive more than 2 to 3 days away from the human skin. Next is pruritus of the scabies may be treated by diphenhydramine or other antipruritic medication. And patient is only allowed to go to school 24 hours after the start of the treatment, because the patient might transmit the scabies, the mite, to the other people in the school. So lastly, these are the treatments that can be given to the patient. First is the permethrin 5% cream or lotion. It is the first-line therapy recommended by CDC. It is effective, well tolerated, and safe. Next is benzyl benzoate 10 to 25% lotion. It is effective, inexpensive. However, compliance is an issue, because using this, it may worsen or cause post-scabitic eczematous reaction. This benzyl benzoate also contraindicated in pregnant women and also breastfeeding women. Next is precipitated sulfur 6 to 10% petroleum base. This is safe for infants, pregnant, and breastfeeding women. Crotamycin 10% ointment is used for nodules in children, and ivermectin is an oral drug, and it is suitable in patients that is unlikely to adhere to topical therapy, and it is effective if combined with benzyl benzoate in patient with scabies. So I think that's all for my presentation. These are the resources. These are my references. So any questions?
Okay, good. We can go for the next.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Wan Umairah binti Wan Muhammad Yusuf, and I'll be presenting about Stevens-Johnson syndrome. Here's the outline for my presentation, which are the definition, classification, and epidemiology. Next, the etiology, pathogenesis, and clinical manifestations. And I'll also include the investigation, differential diagnosis, treatment and management, and also the prognosis and complications. Now we go to the first part, which is the definition, classification, and epidemiology. For the definition, this is according to pediatric protocols. Stevens-Johnson syndrome is severe erosions of at least two mucosal surfaces with extensive necrosis of lips and mouth and a purulent conjunctivitis. While toxic epidermal necrolysis is severe exfoliative disease where the shedding of skin occurs, and it is associated with systemic reaction characterized by rapid onset of widespread erythema and epidermal necrolysis. For the classification, we can see at the right picture, it is the Stevens-Johnson syndrome. And in Stevens-Johnson syndrome, epidermal detachment may occur, but less than 10% of the body surface is involved. And the middle picture is the overlap of Stevens-Johnson syndrome and toxic epidermal necrolysis, where 10% to 30% of body surface area is involved. And for the left picture, toxic epidermal necrolysis involve more than 30% of body surface area. As for the epidemiology, Stevens-Johnson syndrome or toxic epidermal necrolysis is estimated to affect 2 to 7 million people each year, with Stevens-Johnson syndrome being 3 times more common than toxic epidermal necrolysis. And it is more common in older people and women, but it can affect anyone with a genetic predisposition at any age, either sex, and all races. And it is also much more likely to occur in people infected with HIV, with an estimated incidence of 1 over 1,000. Now we go to the second part, which is the etiology. Numerous medications have been reported to trigger Stevens-Johnson syndrome, and in adult, it is almost always drug associated, while for the infection, it is more common in children. And some examples of drugs that commonly cause Stevens-Johnson syndrome are antibiotics such as sulfonamides, amoxicillin, ampicillin, ethamutol, and isoniazid, and anticonvulsants such as phenobarbital, carbamazepine, and phenytoin, and also non-steroidal anti-inflammatory drugs such as phenobutazone and salicylates. For infection, it can be caused by virus such as herpes simplex, enteroviruses, adenoviruses, measles, and mumps, and for bacteria such as streptococcus and salmonella typhi. Next, the third part is the pathogenesis. This is also according to pediatric protocols and latest article from NCBI. The exact mechanism is unknown but appear to be T-cell mediated. And here are some components that are involved in the pathogenesis, which are the first is the CD8 plus T cells are present in the blister fluid and may induce keratinocyte apoptosis. So when the keratinocyte apoptosis occurs, it will result in the separation of the appearance of scalded skin. Next is the CD40 ligand cells also present, and it may induce the release of TNF-alpha, nitrous oxide, interleukin-8 and cell adhesion antibodies. As we go to the granulysin, for the granulysin, fast and fast ligand, they also induces keratinocyte apoptosis. And for cytotoxic T cells, they excitose perforin and granzyme B, which create channels in the target cell membrane and activating the caspases. And for the caspases, it also induces the cell death. And other cells implicated in Other cells implicated in Stevens-Johnson syndrome and toxic epidermal necrolysis, it include macrophages, neutrophils, and natural cells, and also T helper 1 and T helper 2. Okay, and next we go to the clinical features of Stevens-Johnson syndrome. And here are some of the important features. The first is the acute prodromal flu-like symptoms, which are fever, conjunctivitis, and malaise. Next, the patient may come with skin tenderness, erythema target lesions, like in the picture, where the skin lesion has 3 concentric color zones, and also the vesicles progressing to bullae. And for the vesicles are less than 0.5 centimeter in diameter. So when it is greater than 0.5, it is called a bullae. Next, the patient may come with Nikolsky sign, which is the blisters on the face, upper trunk, and also the exfoliation of the skin that will peel off when stroked lightly. Next, there will be buccal mucosa involvement that precedes the skin lesion by up to 3 days in 30% cases. And in the gastrointestinal tract, the esophageal sloughing is very common, and it is manifested by bleeding and diarrhea. In the respiratory tract, tracheobronchial erosions also can happen, and it is manifested by the hyperventilation, interstitial edema, and acute respiratory distress syndrome. Next, we go to the investigation. For investigations, we do the urgent frozen sections of skin biopsy. This is to confirm the diagnosis, and we can see there will be full thickness skin necrosis. And then we do the complete blood count. The findings will be anemia, lymphopenia, neutropenia, eosinophilia, atypical lymphocytosis. And then we do the liver function test. So there will be elevated transaminases and hypoalbuminemia. Urine lysis, we'll find that there will be microalbuminuria, renal tubular enzymes in urine, and also rising creatinine and urea. In the bronchoscopy examination, we'll find the bronchial mucosal sloughing, and in chest X-ray, there will be interstitial infiltrates. And for the ECG, abnormal ECG reading, and for direct immunofluorescence is negative. Then we go for the differential diagnosis. Sorry. Okay, for the differential diagnosis, it can be confused as bullous systemic lupus erythematosus, erythema multiforme, autoimmune blistering disease, and also staphylococcal scalded skin syndrome. Then we go to the treatment and management. It is divided into 3 parts, which is the first part is the supportive care, where we admit the patient to isolation room where possible. This is to facilitate infection and temperature control. And then we also give IV fluid resuscitation for shock, and we use the air fluidized bed. This is to avoid bed sores. This is because air fluidized bed it provides the excellent pressure redistribution and moisture management for complex wounds. So when it will create the environment where it gives the patient an ideal healing environment. Next, we give the adequate nutrition through nasogastric tubes, IV lines, or parenteral nutrition if severe mucosal involved. This is to promote wound healing and immune function, and also host defense mechanism, which is necessary for the survival and prevent malnutrition. Next, the second part is specific treatment, where we eliminate the suspected offending drugs if it is caused by drug. And also we give, this is for children, we give IV immunoglobulins at a dose of 0.4 gram per kilogram per day for 5 days. It's because it will arrest the progression of the disease and help to complete the reepithelializations of the lesions. And the third part is the monitoring, where we need to maintain the body temperature of the patient. We need to avoid excessive cooling or overheating, and then we give do the careful monitoring of fluids and electrolytes, and also we check the intake and output charts. This is related to fluid intake, and also daily weighing and renal profile. And lastly, we go to the prognosis and complications. For the prognosis, Stevens-Johnson syndrome or toxic epidermal necrolysis is potentially very serious with high mortality, and it is predicted by the extent and severity at the presentation. And for the mean adjusted mortality, which is the mortality rate or the death occurrence, is reported for the nationwide inpatient sample in US. It is about 4.8% for Stevens-Johnson syndrome, and the highest is in Stevens-Johnson syndrome and toxic epidermal necrolysis overlap, which is about 19.4%, and for toxic epidermal necrolysis is 14% 0.8%. As for the complication of Stevens-Johnson syndrome, in the acute phase, sepsis is the most common serious risk of Stevens-Johnson syndrome, and the organ failure may occur in the patient, including pulmonary, hepatic, and renal systems. So that's why we do the investigations to test for the pulmonary, hepatic, and renal functions. Next, the most common long-term complications of Stevens-Johnson syndrome or toxic epidermal necrolysis are ocular, such as blindness, cutaneous, such as pigmentary changes and scarring, and also renal complication. And when the mucosal involvement with blisters and erosions, this will lead to strictures and scarring. And lastly, here are my references, and I think that's all from me. Is there any question?
Assalamualaikum. I have a question. So for the cause, is the most common cause is due to drugs, right? Or is it can be due to bacteria infection as well?
Okay, so what is the question?
The most commonest cause, is it due to the most commonest cause, is it due to drug or is it infection or is it both?
Or okay, in adult, it's more common caused by drugs, and for children, it more commonly caused by infection. But in the cases, 80% are caused by drugs.
Okay, thank you.
Thank you for the question.
Can we come to the complication?
Complication.
Yes, this one is a very important guide to us, because sometimes if you are not aware or the progress of the case, you may cause harm to the patient. And in Islam, we are not allowed to harm. Even in medical ethics, your rule is to give benefit, not to cause harm. And even sometimes we are not able to give benefit for the patient, like palliative care, like that. But at least we will not cause harm. Here we can see that under diagnosis or under caring can end to organ failure. Okay, it can affect another organ like the eye, especially if it affects the cornea. The patient may need corneal transplantation, and is it working or not? Okay, even it can affect the other organs. Simple involvement of the mucous membrane can cause a lot of things, structure, so the patient will have difficulty in feedings and he need a lot of intervention for that due to scarring. This an important attention to us during our practice. The other remember you for treatment now like tacrolimus. It is one of the immunomodulating drugs.
Doctor? Sorry, doctor. After you explain about the stricture, the explanation after that is not clear.
Okay, am I clear now?
Okay, a little bit.
A little bit.
Okay, clear.
Okay, so the very important point to remember that tacrolimus, okay, is one of the chemotherapy, okay, or we are telling it about immune modulating drugs, which can be used in severe cases of atopic dermatitis or eczema. And beside the importance of breastfeeding as a prophylactic from eczema, it will drop about 50% of the incidence and the severity which we need to add it, please. Okay, the role of prevention and also family education and counseling is one of our job. So in the future, you are not only a doctor who will get a pen and is going to write medication. No. If you are not counseling the family like this, can come side effect. If you found any problem, come back to me. It will not good practice. So please educate the family, but don't let them panic. Some medication which you are used regularly can cause a very rare complication. We just need you to be engaged in the knowledge. Don't worry, you are using it a lot and it is very minimal possibility. But please, if you feel anything like that, just come back to me. Okay. I think you did for me a good job today. But I was hoping if someone of you volunteer can add some more slides about skin manifestation of systemic disease. You may easily bring a lot and hundreds of slides, but at least the most common. So for dermatology, you are now good the benefit of that. Anyone can do that?
Inshallah, we will discuss further with the other three students. Inshallah.
Okay, so questions. So we will give you your marks. Okay, for Akmal it will be 8.5. For Maria it will be 8. For Noor Sufyan it will be 8. One Umaira will be 7.5. Okay, this is your mark today. Am I clear? Thank you. I'm waiting for to complete these slides and also to add few slides about skin manifestation of systemic disease. And don't forget the flow for examination of the dermatology. It is very important. Okay, thank you. Assalamu alaikum wa rahmatullah.
Thank you, doctor.
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 Thank you,
Hello.
doctor.
Can you listen to me again for
Yes,
my
doctor.
long case?
Yes, doctor.
For my long case. If any group of you are presenting to me a long case, I have my own suggestion, which worked with me. For every case, at least I need 4 candidates. Okay, it will be one candidate will be responsible as a role player. He will be the mother or the father for a baby. The second one will be the doctor who getting the history, and I will examine him about his diagnosis as if he is sitting with you in the sense of the examination, the same which you are doing before. Okay. The third one will do us differential diagnosis as slides and what can be, suppose we are speaking about edema, I will make it more wide. Edema can be nephrotic or nephritic, or causes can be cardiac, can be liver, can be kidney, can be autoimmune, can be like that. Okay, and the fourth one will do OSCE for us. I mean by OSCE, he will present to us slides related to the title. Usually the one on the is going to be examined, better not to give him the knowledge. And all the other you are looking for it is the history, you and history. Okay, if I can be, I'm sending you if you need, okay, but it's for you. If you are able to do the history and you choose your points which you need to start with, all with me. Okay, so someone will present the history, the other one the diagnosis about the case which you are presenting, like whatever you choose. Don't choose two cases from the same system, different system. Okay, and the last one will do for us OSCE. Many pictures, but with many questions for that, including the clinical findings, including the investigations, including the even pathophysiology. Am I clear?
Doctor, how many people do you need? Because one for role play, one for role play for the parents, one to be the doctor asking the question, one for the official diagnosis, and one for the OSCE. So four for one case.
For one case, they will get about 1 hour and another 4. So nearly all the group, everyone will get a job for that. At the end, for my previous groups for year 5 and like that, who already spent a long time with COVID at home, alhamdulillah, I feel that they are good and they can pass the exam, okay? So for every case, it will working with 4 candidates. It may be I will mark only the one whom I am examined, but all of you must share. And it will put it as evaluation also, but maybe without marks.
So all students must at least choose one case and present.
We cannot stay lazy through internet also. We need to be more active until Allah subhanahu wa ta'ala give us forgive and end the issue of COVID. Okay. See you inshallah. Protect me and plan for that. Thank you.
Inshallah, thank you, doctor.
Doktor dah left ah?
Dah.
Doktor suruh buat apa
Tak
tadi?
faham.
Doktor suruh buat case
Tak
presentation.
Itu doktor bagi ke?
Doktor akan bagi 2 case. Satu case tu macam doktor nak 4 orang. Seorang jadi parent, seorang jadi doktor, seorang present differential diagnosis, lagi seorang tu present OSCE. OSCE tu yang ada clinical manifestation, investigation, semua tu.
Oh, okay.
Setiap doktor nak students yang dari group doktor ke macam mana? How macam mana
Yang
sebab
tu I tak
buat?
faham.
Oh.
Sebab dia macam cakap dia macam nak semua orang present. Like dia akan bagi markah just for like that people. Tapi dia macam nak semua orang present. So yang lain tu macam dapat markah sampingan but not official. Apa tak faham kat tadi.
Tadi I dengar macam kalau yang bukan group dia, we only get evaluation but we don't get the marks.
So will we be presenting juga ke? So like macam
kiranya like if you want, you do it for fun, you don't do it for marks.
Bila nak buat?
Itulah.
Bila dia suruh tu?
tu tak tahu.
dengar.
Berapa kes doktor kata?
Doktor
2
bagi 2
kan?
kes. Satu kes tu ada macam 4 orang.
Oh, so 8 orang je lah.
So group dia je lah kot.
Ni saya nak cakap something yang untuk apa tu lusa. Esok dah confirm kan pukul 2 apa tu seminar Dr. Taufik. Okay, so untuk lusa yang BST tu, Kak Farah cakap BST tu ganti sebagai long case presentation. Jadi kita stay as subgroup tu, yang satu group ada 9 ataupun 10 orang tu kan. 9 orang. Jadi nanti leader tu akan contact lah doktor masing-masing. Tengok macam mana doktor akan conduct long case presentation tu. BST tu akan ganti dengan long case presentation. Jadi contohnya kalau hari Khamis tu kan, hari Khamis tu ada 2 grup je. Grup 1 dan grup 4. Grup 1 belah pagi, grup 4 lepas Zohor. Jadi 2 grup tu je lah ada kelas hari tu. Grup lain akan macam tu. Grup lain akan esok pula. Jadi sekarang lah tengah tanya Kak Farah boleh ke kalau nak grup lain nak kacau kan. So sebab pisang kat kalau satu hari tak ada kelas.
Lepas tu doktor masing-masing tu doktor yang tulis dekat dalam jadual tu lah.
Yes. Doktor yang ada dekat jadual tu.
Maksudnya kena contact doktor by hari ni lah to buat presentation. Khamis macam tu.
Betul.
Okay.
Kira ni lah kalau group 4 Amni kan, group 3 Luqman, Idham dengan siapa tu Aiman ke aku tak ingat. Aiman okey. Jadi contact lah doktor masing-masing. Check. Tu je lah.
Lepas tu kes tu kita pilih contact doktor lah.
Kes tu nak dapat mana? Doktor lagi lah.
Tanya doktor lah kot. Okay. Thank you.
Jelas
Jelas.
Nanti saya tulis balik lah kot. Tapi ni nak maklum. Okay. Assalamualaikum.
Okay.
Thank you.
Waalaikumsalam.